Hi, my name is Lauren Berland, and I practice in Dallas. Dallas, in the heart of the great state of Texas. Today, I'm going to share with you a technique for a restoration that I use every day in my practice. Resin inlays and onlays in just one appointment. These restorations have helped me save my patients teeth, time, and money. Over the last 20 years, I've tweaked, updated, and modified these restorations in terms of techniques, materials, and equipment. Wherever you practice, these restorations are durable, aesthetic, economical, and very appreciated. Wherever you are, the mouth is where it all begins. In fact, the mouth is the first source of our emotions. It's the first breath, it's the first sound, it's the first source of nourishment, it's the first way to communicate. For you parents out there, who can ever forget your child's first laugh, first smile, first kiss? Your teeth are weapons. They're even a form of personal identification. In fact, your teeth are so important that they're the only organ where you get two sets of. And now, as the baby boomers are getting older, we're seeing a need for a third set of teeth. And why now? Because the warranty on these 30, 40, 50-year-old silver fillings is running out. So what do? Another amalgam? Gold? Composite? Porcelain? Crowns? Are we going to do this in 2 appointments? Are we going to require temporaries? Are there long-term disadvantages with amalgams? You've got to remember, the amalgam technology is over 150 years old. At that time, people lost their teeth a lot earlier, and they were dying a lot earlier. Now, however, we have a population that is over 50 years old and growing. These are the baby boomers. Now, what are our goals in dentistry? We want to restore function. We want to eliminate caries and decay. We want to repair broken teeth. We want to replace failing restorations. We're concerned with the cosmetics and the smiles of our patients. And ultimately, we want to save teeth and save the function of eating. Now, how are we taught to do silver fillings? We know that silver fillings need bulk. Amalgams need a certain width and a certain depth, a block type of preparation. Because amalgams don't bond to teeth, we have to create undercuts in the tooth so they don't fall out. This further weakens the glass-like nature of enamel. The margins aren't sealed, and especially with these old silver fillings, we know caries detector wasn't used. And what are the long-term effects of temperature changes in the food that we eat? We know that amalgam reacts to temperature. The discontinued thermometers that were made with mercury are a perfect example of how mercury reacts to temperatures and how they fracture teeth. The changes in temperature from hot and cold causes cracks and fracture lines in the teeth. And this eventually causes the teeth to break. Since the amalgams don't bond and seal, this same expansion and contraction can contribute to leaking margins. This allows decay to form. Now, interestingly enough, mercury is considered unsafe in thermometers. Poison labels are required on the packaging of all amalgams. Now, what is an amalgam? The definition is any alloy that contains 50% mercury. A typical amalgam silver filling contains approximately 50% mercury. Mercury is more toxic than lead, cadmium, and arsenic. The Environmental Protection Agency has declared the leftover scrap dental amalgam to be a toxic hazard. Research on the toxic effects of amalgam dental fillings is being conducted in many parts of the world. In fact, the use of dental amalgam is being phased out in many countries. California requires a warning that the people of the state of California have determined that the use of mercury in dental amalgam causes birth defects and other health problems. Mercury can affect your energy levels, your psyche, your digestion, your immune system, your circulation, your respiration. In fact, it can affect your overall health. There are many publications and websites devoted to explaining the possible dangers of dental amalgam. In fact, Lisa Marie Presley was quoted in Rolling Stone saying that her silver fillings were making her crazy. Maybe now we know why she married Michael Jackson. The breakdown of only one amalgam can be the cause of other dental problems. First, the initial cusp broke away from the amalgam. This weakened the quadrant. This caused a whole cusp to break off below the gum line on the next tooth, leaving only 1/4 of the natural tooth structure. And so it goes. We're all noticing a rise in the cracked tooth syndrome, and it's no wonder. The silver fillings in a tooth can weaken the strength of the tooth, and a tooth that has 30 to 70% silver filling will be weakened 30 to 70%. This causes fractures in the tooth. The tooth becomes sensitive to pressure, hot and cold. Often, full coverage crowns, sometimes endo, are often the chosen solution for the restored tooth. How does it progress? First with cracks, then root canal, then a crown, eventually an extraction. This leads to compromised occlusion, neuromuscular problems, and time, money, and more dental treatment for the patient. And of course, most of my patients don't like the way silver fillings look. So what is the problem with posterior composites? Well, we all know they are difficult, they're inconsistent, and they are unpredictable. So what are our options besides direct resin? Indirect resin, gold, crowns. Let's think like our patients. Our patients want to replace these old amalgams, but they want to do it consistently, they want to do it efficiently, they want to do it predictably, and they want to do it in one appointment. So what are the advantages of indirect posterior resin restorations? Well, they look good. You have reduced shrinkage. They help restore the strength of the tooth. There's minimal porosity, excellent marginal integrity, smoother surfaces, kinder to the gums, with less plaque accumulation. They're durable, and many times they can be done in one appointment. Once I heard Gordon Christian say Whittiam is the ultimate criteria for dental treatment. Would I do it on myself? Well, I did. Replacing old amalgams could be the best preventative medicine. It might be the best way to avoid root canals, gum surgery, crowns, and extractions before it's too late. Look at this bite wing. Patient came in, lots of pain. Which tooth would you guess it was? He's got a mouthful of amalgams. He's got a crown on the lower molar. But which tooth is hurting the patient? As you can see, it was the small occlusal silver filling that developed cracks that went to the nerve and required root canal. And when it was time to restore that tooth with a crown, the patient opted to replace the other silver fillings in the quadrant with inlays. Once again, before it's too late and they all need root canals and crowns. Is it time we say goodbye to silver fillings? I mean, adhesive dentistry now offers a more conservative restorative approach. Why take away healthy tooth structure? Why not attempt to save the good and just replace the bad? Indirect composite resin systems are valuable and worthwhile option to preserve our patients' tooth structure and long-term dental health. After all, preserving our patients' natural tooth, whenever possible, is always in their best interest. What are the indications? Well, it's always better to do it before it hurts. An asymptomatic tooth. Wide intercuspal distance. Large interproximals. Minimal cusp coverage. When a highly aesthetic, minimal shrinkage, sure cure, and durable restoration is required. In other words, all the time. What are the advantages in terms of function? Well, we've got an improved marginal fit, high surface hardness, minimal polymerization shrinkage, and a high tensile and compressive strength. You can use it for minimal cusp coverage. Now, I don't know about you, but I find multiple direct composites to be difficult. Why? They take a lot of chair time. There's always isolation and contamination issues. I find it very difficult to replicate nature in the mouth. It's a long appointment and it's very uncomfortable for the patient. And when it's all said and done, these direct multiple composites often yield unsatisfactory results in terms of function and aesthetics. However, when I do it out of the mouth, I find multiple posterior composites to be almost easy. And the best part, with patience and proper training, I've trained my assistants to do these inlays for me. And the best thing about one appointment inlays is no second visit means no temporaries. That reduces cutting the tooth down due to temporization demands, where you need more friction resistance. It also reduces tooth movement during the transitional phase that can result in altered contact or occlusion. And it also eliminates those emergency appointments when the temporary comes off. And from a health standpoint, no second visits means less bacterial contamination between visits. So one-visit inlays eliminate that costly, non-productive, uncomfortable, unhappy patient second appointment. You open and close in just one visit. The tooth loves it. The patient loves it. My accountant loves it. With one appointment inlays and onlays, you save tooth, you save time, you save money, or better yet, you make money. And when you show these kind of restorations to the patient, especially now with digital photography, isn't it better when the patient asks you to fix another tooth? I mean, look at this. Who wants to fix that black tooth now? What are the guidelines in preparing teeth for these restorations? Well, for an inlay, you always want a butt joint margin. You'd like to have 1.5 to 2 millimeters width, at least 1.5 millimeter in depth, and you like to have rounded internal line angles. For an onlay, it's pretty much the same thing, but you like to have 1.5 to 2 millimeters minimal layer thickness for cuspal coverage. So how do we begin? Well, first we remove the amalgam. I like to use diamonds whenever possible because it reduces a lot of the fractures caused by carbides on the tooth. As is often the case, when you take out these silver fillings, you will find decay underneath an old amalgam. Why? Well, with these restorations 10, 20, 30, 40 years old, you know they didn't use caries detector. Did they use magnification? Are the margins sealed? No. This is what happens with these old amalgam fillings. I like to remove deep decay with air abrasion. A lot of times that'll also help preserve the tooth structure and reduce fractures. Now, when the amalgam and decay is gone, it's time to build up, or as I like to say, insulate the tooth. After disinfecting the cavity preparation, I'll use a self-etching dentin primer. After curing, I'll add a flowable composite to the dentin walls, filling in any undercuts that were caused by the amalgam preparation. What am I looking for in a flowable composite? It's very important because in these one-appointment inlays, the flowable composite is your base, and I also use it as my cement. I want something that handles well. No bubbles, stays where I put it, no slumping, no running. I'd like it to mimic dentin in terms of compressive and tensile strength. We want optimal wear resistance, but I want a quick, simple technique with a sure cure. Now, when it comes to the shade, I find that very unimportant. I like to use the lightest, most translucent flowable composite for the best and most rapid cure. I do like a radio-opaque flowable composite to check on the restorations with radiographs. Then, after the tooth has been built up, or as I like to say, insulated, I refine the margins with a fine diamond. And here we are, prepped and ready to impress. For the one-appointment technique, I use hydrocolloid impressions. There's a few essentials you have to be aware of when you're removing amalgams. You need high-speed evacuation systems. You need to use a rubber or latex rubber dam. And you need to have an oxygen mask. Whether your patient wants to use nitrous oxide or is content simply breathing oxygen, you want that mask on to limit their exposure to the amalgam. That's also why you want high-speed suction and to use a rubber dam. Now, before I go much further, there are some essentials that you must have in your office to remove amalgams. This is to protect you and to protect your patient. You have to have high-speed evacuation and suction systems. It's essential to use a rubber or latex rubber dam. And you have to use an oxygen mask. If the patient doesn't want to use nitrous, they have to have oxygen because of the vapors from removing the amalgam can cause them to ingest mercury. After the teeth are prepared and ready to impress, for the one-appointment inlay, I find the hydrocolloid impressions to be extremely useful. Their 1.5 minute set make them just ideal for one-appointment inlays and onlays. Once we have the hydrocolloid impression, we begin with the lab work. We start out using a dye silicone to create the dyes. After we take the hydrocolloid impressions, we can pour them up immediately with silicone to create the dyes in the laboratory. I like to use a removable dye articulator for easier and better handling. It's great for preserving the occlusal integrity and maintaining interproximal contacts. And best of all you have to do to separate the dyes is use a scalpel. Once the dyes are complete, we wax out the undercuts. Then we apply the dentin shade. Then we layer the enamel shade over the dentin to build the onlay. You can do this either using a brush or apply directly from the dispenser. Making these composite restorations outside of the mouth have a lot of advantages. We can use light cure, pressure cure, heat cure. There's simply no comparison between the strength of these materials made in an oven and those cured in the mouth. And of course, it's much easier to finish and polish the occlusal anatomy and morphology outside the mouth. How about these wide interproximals? This is almost impossible to do direct. I don't care what matrix system you're using. However, when you do this outside the mouth, you have complete control over the contact, the morphology, the fit, and the color. It's almost easy, and it's done in one appointment. How about adjacent class 2 preps? Once you take out these silver fillings, it's not at all unusual to find decay caused by interproximal fractures. One more time? Okay. Adjacent class 2 composites can be difficult and unpredictable because of the problems associated with the depth of cure and shrinkage. However, with one appointment inlays, they are much easier. Now, I always take 2 impressions when the interproximals are involved. One for the working model and one for a check model. Before and after. Very difficult to do in the mouth, much easier to do outside the point. Very difficult to do inside the mouth, much simpler and better to do outside the mouth. Now, I was talking about the rubber dam. When I'm doing quadrant dentistry, I find the split rubber dam technique very helpful. It's quick, it's easy, and it prevents the patient from swallowing the mercury in those silver fillings. It also offers great isolation, high visibility, and allows me to provide better dentistry for my patients. Let's go through the steps here. Patient presents herself with a broken cusp. At this stage, she opts to replace all the mercury in the quadrant. We take the hydrocolloid impression, go to the laboratory, and that same appointment, we seat the final restorations. Let's go over this next case. Patient came into my office with a broken cusp. Now, what happened here? Obviously, this is not the first or the second time this tooth has been worked on. I'm sure that originally she had quadrant dentistry of amalgams. For whatever reason, the amalgam on the second bicuspid failed, and it was replaced with a composite. Why did this composite fail? Well, because the tooth was originally prepared for a silver filling. You simply cannot easily replace a silver filling with a direct composite. The preparation, as I explained earlier, is just too large. So what are our options? A crown? Well, a crown we know is going to entail removing a lot more tooth structure. Another composite? It's already failed. Gold? I don't think this lady's going to accept that on a bicuspid. So how about a resin inlay? This is what I would do for myself. First, I isolate with a split rubber dam. Then I pre-wedge, remove the caries, use self-etching primers to build the tooth up, take the impression, and go to the laboratory. Before and after, and in one appointment. Do you think she was happy? The patient she referred me told me she was happy. Do you occasionally have large cervical restorations that may pop out? Well, if you do them indirect, they'll last a whole lot longer. How about a patient with multiple problems? She has cracked silver fillings. She has perio problems. She has loose teeth. Why not kill 3 birds with 1 stone? We remove the silver fillings, take the impression, while my assistant is fabricating the splinted inlays, my hygienist does scaling and root planing, removes the calculus. Then, by the time the hygienist is done, we seat the splinted inlays. So we did perio treatment, splinting, and restorative dentistry, all in just one appointment. My next case is a dentist who came from out of town who was seeking my assistance in cosmetic dental treatment. During the consultation, he saw how we were working on another patient, replacing her silver fillings with resin inlays. At that time, his priorities changed. This gentleman is a dentist who came in from out of town to seek my assistance in fixing up his smile. During our consultation, I showed him this technique for replacing amalgams with one-visit inlays. He was so excited, he changed his priorities. He decided at that moment to first replace all of his silver fillings. As you can see, he has several 35-year-old or more amalgams. And if you notice, he's missing his upper second molars. These upper second molars had gone through amalgams, composites, endo, crowns, and finally the fractures caused those teeth to be removed. He doesn't want any more teeth removed. So we begin, after anesthesia, placing the split rubber dam, which allows me to have great isolation and visibility and to protect the patient in the whole quadrant. We remove the silver fillings, place the decay detector, insulate them with self-etching primer and flowable composite, impress, and go to the lab. A few hours later, 8 large amalgams, all completely restored with one appointment inlays. This young man came to see me from Florida. He wanted cosmetic dentistry. As you can see, he could use cosmetic dentistry. As you can see, he has some more pressing problems. Because this young man was coming from out of town, we try to minimize the number of appointments. I'll go over how we can do a whole side, top and bottom, of complicated restorations in just one appointment. When we begin, I like to get the lower numb first. That's because it takes the lower, as you know, more time and to get numb, and it stays numb longer. Then I'll infiltrate the top. Because the maxillary gets numb fairly quickly, I'll begin preparation with the top. I'll pre-wedge the interproximals. This will open the contacts now for tight contacts later. It also helps avoid scratching the adjacent teeth. The amalgams are removed and caries detector placed. Caries is exposed. Caries excavation. I really like this spoon excavator from American Eagle. It is TNT tough. Then we disinfect, apply the self-etching primer, use composite flow to build up and insulate the tooth. When I apply the flow to fill in the undercuts and insulate the tooth, I'll use an Explorer to agitate it before curing to eliminate any bubbles. Then I'll take the hydrocolloid impressions. I take as many as I feel I need. In this case, because there were 4 interproximals, I took 4 impressions, and I took all 4 in less than 10 minutes. As my assistant, technician, artist, craftsman begins the model work on the top, the lower is numb and ready to go. We place the split rubber dam, remove the amalgams, caries detector placed, build it up with flowable composite, refine the preparations, and we're ready for another impression. And meanwhile, back at the lab, my assistant is finishing up those top restorations. She begins by waxing out the undercuts, build up the restorations in resin, adjust and polish the interproximals, apply separator on the adjacent interproximal walls and interproximal restorations, start the adjacent restoration, checks on the untouched model, and she's ready to impress. When the restorations are complete, we place them on the untouched model to make sure the contacts are tight and sealed, and then we're ready to process. After they are processed, Then it's time to prepare to bond the inlays back in place. Once again, I apply the split rubber down. Now that the upper inlays are finished, it's time to bond them in. I have a few little tricks that I'd like to share with you. First, I adapt the wedges. I use a Bard Parker knife to just remove a thin layer of the top triangular portion of the wedge. This is my modified wedge. Then, I'll place the split rubber down to isolate the teeth involved, and then I will apply these wedges, these modified wedges, interproximally below the gingival floor. Sometimes I'll apply Expasil before I put the wedges in. The inlays are oriented with stickies so that I can easily place them back on the teeth. We isolate, we etch, we rinse, we dry. As you can see, the split rubber dam really isolates and maintains a dry field. Apply disinfectant, air thin, and then the bonding agent. I seat the upper restorations with vibration. My assistant will floss to remove excess cement. Then we'll remove the wedges. I find this instrument from American Eagle really great for seating these inlays. One end is an acorn for applying pressure to the inlay to seat them properly, and the other end is a pedal to remove any excess before the set. Then we cure and finish. I like to use this TNT by American Eagle to remove any excess cement below the gum line and at the margins. So once the top quadrant is complete, it's time to move to the lowers. And you're done. 7 complex, large restorations all in one morning. Most of the instruments that I showed in this demonstration are available through American Eagle in the pack kit. That's my posterior anterior kit. These are the instruments that I use virtually for almost every procedure. Now, when I'm doing 1 or 2 teeth, I like to use the magic clamp. It's fast, it's easy, and effective. It comes with a mini rubber dam. This is the magic clamp in place without the rubber dam. This is the magic clamp in place with the mini rubber dam. In this case, we've got a second molar with a large broken down amalgam. I isolate the tooth with the magic clamp, remove the amalgam, caries detector. After we remove the amalgam, we place the caries detector. The magic clamp allows me to have a clean, isolated, dry field. And this is very difficult to achieve on a second molar. The tooth is insulated and built up. Etch the tooth prior to the cementation of the inlay. I leave the magic clamp on during the cementation process. And the final inlay. Thank you so much for your time. I hope you enjoyed my presentation. Thank you.